بسم الله الرحمن الرحيم وبه نستعين. أهلا وسهلا بالجميع في الويبينار الخاص بالجمعية السعودية لطب أسنان الأطفال الأسبوعي. كل يوم أربعاء احنا معكم as usual إن شاء الله. معكم الدكتور حازم التميمي، أحد أعضاء مجلس إدارة الجمعية، ونرحب فيكم جميعا في الويبينار الأسبوعي، وإن شاء الله نتمنى أنه يكون في مستوى توقعاتكم. طبعا الويبنار معتمد بساعتين من الهيئة السعودية للتخصصات الصحية للأعضاء المسجلين في الجمعية معنا، علما أنه جميع الحضور بيحصلوا على شهادات حضور، ومن هذا المنبر احنا نبحث يعني للغير مسجلين على التسجيل في موقع الجمعية الموجود على حسابنا في تويتر للاستفادة من الساعات المعتمدة، وكذلك من الأنشطة والمميزات العضوية الأخرى اللي موجودة في نفس الموقع الإلكتروني للجمعية، تقدرون تطلعون عليها. I will speak in English because some audience not speaking Arabic. طبعا باي ذا واي نسيت اللي حيشاركني إن شاء الله اليوم السكند مودريتور الدكتورة وسام المنهوري. إن شاء الله she will introduce the second speaker. Okay, I will talk in English for some audience who is not speaking Arabic. We have some of them from outside and inside Saudi Arabia. We want to welcome you all in our webinar and wish it will be up to your expectation. Our first speaker tonight will talk about subject related, to everybody, for every home, okay, which is child abuse and neglect. I think it's an important topic, and our country, wallah alhamd, have a great success in this field, with organizations, societies, and children's rights, and also care afforded to minors in our country. While unfortunately in some parts of the world, they are running behind in this field. And to know more about this, let me introduce you to Dr. Dima Farsi. طبعا هي بالنسبة للي في جدة، البيبل اللي في جدة, she's a well known. تمام. الدكتورة ديما فارسي, she's associate professor in the Department of Pediatric Dentistry at King Abdulaziz University in Jeddah. She obtained her clinical certificate in pediatric dentistry and her Master of Science degree from Tufts University. She is also a diplomat of the American Board of Pediatric Dentistry. طبعا ما شاء الله هي عندنا في المملكة العربية السعودية في المجال هذا, وحابة أرحب فيها. Welcome دكتورة ديما. The mic is yours. Just I want to tell something before Dr. Dima start. Everybody, if you have questions, okay, you can write it in the question and answer. Okay, you'll find an icon Q&A. Okay, Dr. Dima also, she might share something with you. You can also write it down in question and answer. At the end, we will address it all, inshallah, and depend on the time. That's all. Welcome, Dr. Dima. The mic is yours.
Okay. Dr. Hazem for the intro. Good evening, good afternoon, good morning, my audience, wherever you are. It is certainly a pleasure to be speaking with all of you today. The talk is gonna be short. It's not too long. I'm gonna try to make it as light as possible, although the topic is really heavy and emotionally draining. But we're going to try to make the best out of it. To make this session interactive, I'm going to be asking questions throughout the talk, and you can type your answers. So I'm going to look at them and see if you're following with me. But unfortunately, I'm not going to be able to answer questions until the end. So the chat is going to be just for responses to my questions for the time being, okay? First, I would like to warn you that there will be graphic content, there will be emotionally disturbing images and videos, but that's just part of the learning process. Okay, let's see why this was not moving. Okay. Okay, so I apologize about this video, but this video was shared on Twitter by a mother who was documenting her husband's abuse to their baby. And things like this do happen all the time in all countries, and it does happen in Saudi Arabia. Unfortunately, only a small percentage of these are brought to the attention of the public and the authorities. Now that we have, I got your attention, I apologize, I wasn't aware that there will be non-Arabic speaking attendees. So I'm going to try to translate everything that I mentioned in Arabic. This is a little bit slow, I apologize. Let's see what's happening. Let's do this. Okay, so we're going to speak about child abuse and child neglect. I would like to begin بحديث شريف. قال رسول الله صلى الله عليه وسلم ليس منا من لم يوقر كبيرنا ويرحم صغيرنا. So this is a saying by Prophet Muhammad that you are not considered a Muslim if you don't respect the elderly and you have mercy for the young ones. The first ILO, the intended learning outcome, is to differentiate between child abuse and child neglect. And for this, I'm going to tell you 3 stories. And if you know the answers to my questions, kindly type them in the chat box. The first is a scenario that happened at our clinics a few years back. I would say 15 years back to be more accurate. There was a girl who was 8 who was brought by her mom and dad to the clinic. And one of my supervisors was trying to demonstrate how you do an examination and treatment planning on a child. So she had about, I would say 10, 12 students around her. They came to the clinic with her to observe how she's going to deal with the child. The child was very apprehensive. She was very afraid, and I think she was overwhelmed by the amount of doctors around her. So she was refusing to open her mouth and cooperate. The dad tried, the doctor tried, but the child did not cooperate. So all of a sudden, the dad smacked her on her face in front of everybody. What I'm asking here is what type of maltreatment do you think this child received? Okay, very good. Okay, very good, very good. So that is abuse. Yes, this is correct. This is abuse. The second scenario, it was a mother who brought her young 5-year-old boy to the clinic. She was well dressed, and we understood that she was a full-time employee. She came with a chief complaint that my child did not let me sleep all night. He was crying the entire night. Please treat whatever he needs to be done so you relieve his pain and enable us to sleep. So the doctor examined the child and explained to the mom that the child has severe early childhood caries, he has multiple carious lesions, and he needs intensive treatment. And then the mom said, no, I don't have time for all of that. Just do whatever is bothering him today because I can't bring him back. I am very busy. Okay, very good. So everybody's saying neglect. That's very good. This is certainly neglect because the mother knew that the child needed more treatment, but she refused because she said that she is too busy to bring him. The third and last scenario was also another patient that came to our clinics a few years back. We did treatment planning for her. We explained to the mom the extent of treatment that the child needs. The child came for one restorative visit, and then the mother vanished. The child never came back to our clinic. About a year later, the child came back, of course, with more extensive carious lesions, a much worse case than a year earlier. And then when we asked the mom, like, why didn't you bring the child? You only did one, you only came for one restorative visit and then you never came back. The mother said that unfortunately the child's sibling the mother's other child was diagnosed with leukemia, and that she spent the last year most of the time at the hospital. So she really didn't have time to bring the other child for dental care. Can we consider this as neglect? No. Okay, very good. Okay, I see the majority says no, and that's the correct answer. You cannot, because there was a reason for this mom not to seek care, because it was something of a bigger magnitude, and probably she was overwhelmed. It was a recent diagnosis, and she was spending most of the time, as she said, at the hospital with the other child. Now, there are things that you can do to help families like this, but I just wanted to highlight the difference between neglect and a mother who really sincerely could not bring the child for care. So child maltreatment is divided into two things: commission, something that you do or inflict on the child, and that is child abuse, or something that you omit, like care that you don't provide to the child, and this is child neglect. To define child abuse, it is any word or intended act that can cause harm or potential harm or even threat to harm the child. Whereas, this is not working again, sorry. Whereas child neglect is defined as the failure to provide the child with basic physical, emotional, educational needs and to protect the child from harm or potential harm. And among the definitions of child neglect is dental neglect, which we will get to. What is very important to remember is that neglect must be considered in the light of the cultural norms for that society. For example, if a mother brings her child to the clinic in Saudi Arabia, barefooted, not wearing anything on his feet and not wearing a t-shirt, this would be considered neglect. But if your practice is somewhere in rural Africa, for example, and the child comes without shoes and without a t-shirt, that may be considered normal. So you always have to remember what is normal for that society and what is not before you can say child neglect or child or not neglect. The American Academy of Pediatric Dentistry defines dental neglect as the willful failure of a parent or a guardian to seek and follow through with treatment necessary to ensure a level of oral health essential for adequate function and freedom of pain and infection. So it has to be willful, and the parents or the guardians must be knowledgeable. They understand the magnitude of the treatment that the child needs, the situation that the child is in, and still decide not to bring this child without any justifiable reason. So that was the first ILO. The second ILO is to differentiate the different types of child abuse. And I apologize again, this video is very brief, but it's in Arabic, and I'm going to translate what the child is saying. Please tell me, can you hear what the child is saying after I play the video? Just let me know if the audio is clear.
من دون سبب يعني هيك يضربك بركان عصبي كده لما يكون برا وقاعد وجاي من برا طفشان يقوم يضربني على طول ما يبغى يشوفني يقول ما يبغاني وأمك إيش كانت تسوي لما كان يضربك؟
So basically this is a very brief part of a long interview with this 9-year-old child who was burnt, beaten, whipped by his parents. It was started with his dad, and then it followed with his mom. And then he said that his dad told him occasionally that he does not want him. What do you think the type of abuse that this child received from his parents? Okay, brilliant. I see physical, I see emotional. Excellent. So there is physical and emotional abuse. Excellent, excellent, everyone. So the types of abuse are basically three. Physical abuse, and there are different types of physical abuse. It can be kicking, it can be punching, it can be beating. This is actually an actual footage from an elevator camera, and this was the babysitter punching this child. It could be biting or it could be burning. How do you know that this is an adult bite? If the intercanine distance is more than 3 centimeters, this is indicative of an adult bite. Can someone guess what these burn marks are? Cigarettes, perfect. Yes, these are cigarette burns. Excellent, everyone. So again, burning is type of physical abuse. And then there's the emotional abuse, and emotional abuse usually goes hand in hand with any other type of abuse. So even if the father did not tell the child in the previous interview that he does not want to see him, the act of hitting him and making him feel hated is emotional abuse on its own, okay? And then there is sexual abuse. Sexual abuse does not necessarily mean rape only. It can be harassment. It can be touching the child in a silly way, looking at the child in a silly way, engaging the child in a silly activity. These are all types of sexual abuse. And female and male children are sexually abused. Okay, so it's not just a female problem. I wanted to share here with you a story of, and I'm very proud of the Indian women in this story. So this guy, Aku Yadav, I don't know if you heard his story before or not. So he was a gangster, and his specialty was rape. He used to rape women over 12 years in his village in India. And he would rape any woman that he sees in the house. So he goes in, he could rape the mother and the daughter. He had raped women or girls as young as 12 years of age. So what happened is he used to bribe the policemen. So they were on his side and they protected him. And basically nobody was able to stand in his way. He was a robber, he was a murderer. He also was associated with 3 homicides. And rape was his big thing. Anyway, so one day he raped a girl, and then her family went to his home and burnt it down. So to be protected, the police took him in custody and said, we're going to have a trial. And basically, they intended to protect him from the angry family. The rumor was that he was going to be released after the hearing. So there was going to be a legal hearing at the court, but odds were he was going to be released. When he came into the court, actually, he looked at one of his victims and he told her, if I can do it, I'll do it again. Because people were raged over years, over 400 women came to the court in this, to the vicinity of the court, holding with them chili powder, pepper, and house knives. When he said this, and then the policemen at the court were laughing from the comment, he said, women attacked him, and then they managed to kill him and beat him to death in the court vicinity. What happened is that police caught 5 women that they thought were initially, or the, how can I say it, the nucleus that started this movement. They had to drop the case eventually because 200 women came and told the policeman that I am one of the 5 women that initiated the attack on the man. And of course, they had to drop the case because they couldn't really convict anyone. 200 women came and said, I am one of the 5. So I'm very proud of Indian women, and I'm glad that India was able to get rid of this man. So this was about sexual abuse. Now we get to another type of abuse, which is called Munchausen syndrome by proxy. I don't know if you've heard about it or not, but it's a pediatric condition falsification. What happens is that the caregiver, oops, let's see where this is happening. Okay, so what happens here is that the caregiver brings the child falsifying illnesses. She comes and she complains like, my child doesn't sleep at night. My child has so much pain from his teeth. My child has shortness of breath. My child doesn't walk properly. He cannot swallow or whatever. They make up symptoms and bring their child to for medical care or dental care as well. It is the most difficult form of child maltreatment to diagnose and treat, and it is very common in intellectually disabled children. So you ask, why would the mother do that? Why would the mother bring the child all the time to the hospital, spend time at the hospital, and pretend that the child is sick or something is wrong with the child? It can be psychosis. The mother can have a mental problem, or it could be that she wants attention or to obtain money or services. Again, sometimes these mothers come from broken homes. She wants the attention of the doctor. She might have a crush on a doctor. She might need attention. I forgot the word for that. Reimbursement for her visit or something. So there are many reasons that mothers could use their children as scapegoats to fulfill needs that they have. So what are the oral aspects of physical abuse? To start with, physical abuse. 50% of physical abuse results in facial or head injuries. 25% of physical abuse occurs around the mouth. Lips are the most common site for inflicted oral injuries, followed by the oral mucosa, teeth, gingiva, and the tongue. This is a very sad case. This is a child, a homicide victim. He was killed by his parents. You can see the wound here. I don't know if you can see it on his chest. And this is him at the morgue. And these are some of the lesions that he had on his face. If you look with the blue light narrowband illumination, you can see the extent of the subcutaneous hemorrhage. It doesn't even show that much, maybe because of his dark skin, but you can see it with the light. So this child, poor thing, before he died, he really sustained a massive amount of trauma. Okay, what about sexual abuse? Although oral cavity is a frequent site for sexual abuse in children, visible oral injuries or infections are usually rare. Oral and perioral gonorrhea in prepubertal children is pathognomonic for sexual abuse. So if you see a prepubertal child with perioral gonorrhea, this child most likely has been sexually abused. Unexplained injuries or petechiae in the palate, particularly at the junction of the hard and soft palate, is also a sign of, could be a sign of sexual abuse. But here differential diagnosis is very important, because it could be a bleeding disorder, the child could be on chemotherapy, other systemic conditions or medical management could cause something that looks like this. Human papillomavirus infections may also be sexually transmitted. Bullying is very important and has been lately incorporated in the child abuse chapter in the American Academy of Pediatric Dentistry Reference Manual for 3 reasons. Because children with orofacial dental abnormalities are frequently subject to bullying. So children with flared teeth, with excessive overjet, big teeth can be subjected to bullying. And bullied children may suffer serious psychological consequences. Sometimes they can commit suicide or become really violent and go and attack and do mass shooting as a result. So it is very important that healthcare providers, including dentists, should ask patients about bullying and advocate for anti-bullying programs. The third ILO is to recognize physical and behavioral indicators of abuse. This is an awesome photo. I really like this photo. It's very sad. It's for an Iraqi, a girl from Iraq, a refugee. And if you just look at her face, you can see like tons of expressions. You don't know if she's hopeful, or if she's just really devastated. Is she sad? Is she happy? Is she smiling? It is very important with children to really look at them, because just looking at children, they can tell you so much. So the physical indicators. The first, for the extraoral examination, there can be scattered fractures, bruises at different surfaces and various stages of healing. This is very important. If there are various stages of healing, these are red flags, okay? That means that there are recent and there are old ones, and it's a continuous process. Unexplained bruises, unexplained injuries, bruises in the shape of an article. Sometimes like this child over here on the top, you can see that these are obviously wires. Sometimes you can see a fork, a cigarette, something like that. Bruises in the shape of the article or cigarette immersion burns, bite marks of an adult as well. And then intraoral examination. Frenal laceration is very important. Frenal laceration usually tells you that there was an object, whether it's a body part or an external object, that directly hit the child. So it is less likely a car accident or a fall. It is usually a hit that was inflicted to the patient's face. There can be, tooth fractures, palatal lesions, lacerations, ecchymosis, jaw fractures. And then there are the behavioral indicators, which we usually miss. You can notice that the child may be uncomfortable with an adult, and it's much easier to notice if you've seen the child before the abuse happened. So you can see the difference between the child before abuse and the child after abuse. But sometimes you see a child for the first time that has already been abused, so it's very, you don't have a baseline to compare it to. Sometimes the children will be very fearful. They have nightmares, depression, unusual fears. They have habit disorders. All of a sudden the child is sucking or biting or self-mutilating himself. The child has attempts to run away, extreme sexual behavior. The child may have like an extreme sexual drive for his age, sudden changes in self-confidence, headaches, stomach aches. Usually teachers notice these things because they can tell you that the child was doing way better, and then something happened, and the child is a different kid now. The child can be frightened from the parents, afraid to go home. There is school failure, extremely passive or aggressive, failure to gain weight, desperately affectionate or really wants attention, and they can have a big appetite and start stealing food. This is also one of the things that abused children undergo. The fourth ILO is to describe the healthcare provider's role in cases of child abuse and child neglect. So I don't know if you know this case. This was a famous case that was all over social media, I think a year or two ago. This was a child that was featured beating his little kid. The kid was very young, this little kid here in the photo. He was beating her continuously. The child was crying and he continued beating her. And this was leaked by the child's mother. Okay, so many of the audience from Saudi might remember this case. But what I want to highlight is this video in which the dad explains what he did. And I'm going to translate the English to English in a bit.
كانوا استخدمت المقطع هذا بشكل كيدي علشان توصل لأغراض ماني عارف ايش هي، وانا اعتذر منكم جميعا صراحة، واعتذر من النائب العام العالم كله اللي شاهد هالمشهد.
So basically, the dad came out after the video was leaked. The dad publicly spoke to officials in Saudi and the community, and he was saying, first of all, I apologize for what I did, but I had my reasons. This video was taped by my wife, who has disappeared now. She left me with 4 kids, and she intentionally taped me to use this against me or blackmail me. And I am all alone, taking care of 4 kids, and I'm under so much pressure, blah, blah, blah. What I'm trying to get to is, can we sympathize with this man or any man in his position? Would you sympathize? Excellent. Okay, so no, definitely. That's what I wanted to know. You cannot sympathize with a man like this. He certainly has issues. I'm not undermining his issues, but you are never excused to put all your stress or anger on a little child. Whatever your excuses are, get the child safe and then deal with your stresses, with your problems, go report to the police, do whatever it is that you want, but you do not hold it against the child or do not make the child pay for things that you're suffering from. Okay, very good. So yeah, this is what I wanted to see. You cannot sympathize with abusers. So what are the obligations for the dentist? You have to stop child abuse. If it ever comes to you, please make it stop there, okay? There are 3 roles for dentists. The first is to investigate and identify can. You cannot see a child with abuse and not pay attention to that. You need to, if you find anything that is worth suspicion, you have to investigate and reach your diagnosis as much as you can. At least do your investigation and be ready to report. And then you have to treat the victim of child abuse and neglect in terms of dental needs. Try to treat as much as you can, because the odds are this abusive parent is not going to bring the child again. So what we always say, treat the child, treat as much as you can. If you can do more than 1 tooth, more than 1 quadrant, do as much as you can, and do definitive treatment. Don't put temporary fillings, don't put something you're not sure of, don't use a new material that you're testing. Do definitive treatment and something very radical, and do as much treatment as you can. And then report the case to the proper authorities. In terms of investigation, what should you ask? It is very important to obtain thorough dental and medical history. Again, we said some medical conditions or management or medications for medical conditions could resemble, for example, sexual abuse. Or this child, if, for example, this child is an ADHD child, he might be prone to trauma more than children who are healthy, let's say. You have to obtain trauma history. So if you see trauma or you see something alarming, you should obtain its history. When did it appear? Who was with the child? When did it happen? What happened since then? And you should, as much as possible, try to obtain 2 different reports from the child and from the parent separately as much as possible, and then try to compare. And you have to be very smart about it. For example, ask the mom to leave or the dad to leave to be able to take radiographs, for example, or take the child to the radiograph room if it's not inside your clinic. Try to be alone with the child to ask him lightly about what happened, okay? And then ask the parent and then compare their answers. And use open-ended questions. Do not say, is this a fall? Were you hurt at school? Is it something that you did while you were on your bike? Let the child answer. Ask open-ended questions and listen to everything that the child says, okay? Your questions should include how and when did the incidents occur? Who witnessed the injury? Was the child on his own? Sometimes it could be an injury, but it shows that there was neglect. Nobody was supervising a young child doing whatever this child was doing, okay? And then where were the child and the supervising adults when this injury took place? How can you differentiate between abuse or an accident? It is not very easy, but there are red flags that you should watch for. Cases in which the pattern of injury is not consistent with the history offered. For example, there's frenal laceration and a fractured incisors, for example. And then the father might tell you, oh, well, he rolled off his bed and fell. Usually falling off bed is not going to cause frenal laceration and a broken tooth, okay? And then accounts for more than 2 individuals that conflict, okay? So the account you received from the child is different or is not consistent with what the dad said, or accounts that change over time. If you change this question, you get different responses. So these things should be alarming. I'm not saying they are necessarily abuse, but I'm saying they could be alarming. Things to be suspicious about: child covering the body with weather inappropriate clothing. A child coming in the very hot Saudi Arabia weather in August, for example, wearing a jacket. Then it's probably that the child or the parent is trying to hide something. Again, I'm not saying that these are distinctive and very conclusive, but they are red flags. The child is too scared or too quiet, just looking at the parent and making the parent answer on his behalf. The parent becoming angry with your questions, or it seems like the parent is very careless, has no clue what happened to the child. Or when there are multiple injuries in different healing stages, and usually they are in different body parts, okay? These again are red flags to watch for. Then we said after you do the investigation, you treat the child, you provide definitive treatment, and then you send the child, and then you report the case. This is a video I want you to watch. It's very brief, but it's very important.
So when you think about child abuse, it can come at any time, and it can come from a lot of different directions. It can come in just a regular patient visit that you see. And an example that I have is a patient that I was seeing for iron deficiency anemia. It was going to be a quick 10-minute checkup. I always check for bruising, and so I looked at the patient's arms and legs. And when I looked at the arms, I saw the marks from cutting. And that led to then questions of, do you cut? Yes, I do. Do you feel safe at home? No, I don't. And then that whole visit took a very different turn.
So this is what I want you to do. If you find something suspicious, do not leave it and just focus on the whatever dental treatment you want to do. You really have to look at the child as a whole. The next ILO is to identify some agencies to contact in cases of suspicious cases of child abuse. When in doubt, call it out. If you're not sure, you're better calling than not calling. The number in Saudi, does anyone know what is the number, the hotline in Saudi to call? 1919, excellent. So it is 1919. There are other agencies that you can call, but the safest bet is to call 1919, but you can report it to the police, human rights, public and private hospitals, but 1919 is your safest bet. The final and last ILO is, how do you report? Demonstrate the appropriate reporting system. In Saudi Arabia, you have to report when you have reasonable cause to suspect. You don't have to be 100% sure. If you suspect, you are obligated to report. Who reports? Anyone who becomes aware of it, whether you're a public servant, civilian, military, as well as an employee of a private or a public sector. This was a royal decree by King Abdullah, Allah yarhamu, in 2013. It also said that dental professionals are mandated by law to report suspicions. People, again, I'm saying suspicions. You don't have to confirm. It is not your job to confirm. The agency's job is to confirm and investigate it further. If you suspect, you report. What happens if it's a false alarm? I reported the case and it turned out that the child did fall off his bike, for example, or the mother really did not know how the child inflicted the trauma. You are exempted from liability, meaning no harm is going to come to you. Nobody is going to tell you why. I don't know what Hitler is saying, but okay. You're going to be exempted from liability, okay? I just wanted to show you how fast they respond. This is a test I did with one of my friends to see if they respond quickly or not.
لتقديم بلاغ جديد اضغط الرقم 1 للاستعلام عن بلاغ. السلام عليكم، معك الأخصائية روان تفضل.
السلام عليكم. So I just wanted you to see that they do respond fast, and we tried at different times and more than once, and they always responded really quickly, and they're very professional, the dispatchers who take the calls. How do you begin a report? You have to give your name, your position, place of employment, and the reason for your call. So I am Dima Farsi. I am a pediatric dentist at King Abdulaziz University Hospital University. And the reason for my call is I would like to report child abuse, okay? And then they're going to ask you more questions like to evaluate or to assess the child's behavior. Why did you suspect that? What is your name? What is the child's name? Where does the child live? And they take further investigation, and that's all you need to provide. They're going to investigate further and going to take care of it. There is nothing more for you to do. Pay attention to children around you. Child abuse is everybody's business, and it is very easy to miss something that you're not looking for. This man here is opening the car door, or this lady is opening the car door, focusing mainly on what's ahead of her, not noticing that there's a bike coming very fast at her direction. If you're not looking for it, you will easily miss it. So please keep your eyes open. I don't think we have time for this last video. If you get a chance, watch The Trials of Gabriel Fernandez on Netflix. It's a docu-series on a child that was abused. It's an excellent, but again, emotionally draining. And at the end نبدأ نختم بكفارة المجلس. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. And happy and blessed Ramadan, everyone. The dua دخول Ramadan. And I think we can do the questions, Q&As now, right?
Okay. الله يعطيك العافية دكتورة ديما. ما شاء الله تبارك الله. يعني أنا بالنسبة لي استمتعت حقيقة، استمتعت جدا. وما أدري لأنه المحاضرة ما شاء الله فيها أشياء، فيها فيديوز وفيها كذا، ونولج ما شاء الله. يعني أنا بالنسبة لي وأنا في الفيلد من زمان إلا أني استفدت والله كثير بالعكس من علمك. جزاك الله خير والله يجعل في ميزان حسناتك. نروح للكويستشنز. تمام. نبغى نمر عليهم على السريع دكتورة ديما. في سؤال يقول لك إنه I will report the abuse or neglect to which authority. طبعا أعتقد هنا في السعودية يقصد.
أيوة. So we decided 1919 is your safest bet.
Okay. طيب second question اللي هو اوكي ما شاء الله الأسئلة كثير فأنا قاعد أروح تحت. طيب يقول لك how do we differentiate pattern child syndrome and shaken baby syndrome? Okay. Did you see this question?
لا, I heard it. صراحة I don't know the answer to that.
Okay.
I know shaken baby syndrome. I know what it is, but I don't know how to explain it. So I apologize. I can, if you want, you can send me your email. I'll look it up and then I can email you the answer.
Okay, sounds great. طيب دكتورة، في another question هنا يقول لك do we report يعني to the authority directly اللي هو 1919 or we engage يعني our supervisor first?
If you're an undergrad, I recommend, if you're a dental student, I recommend yes, run it by your supervisor first. But for us at our level, yes, we report. I even asked one of my colleagues at the hospital because we're in the dental hospital and they have the medical hospital. I asked her, do we report to you first and then you take it to 1919? I just report immediately to 1919. So the more you just shortcut everything and go to 1919. It is better, but again, please check with your facility, like check with your university or wherever you're working. Maybe they have a different system. Better be familiar with the system of your place of employment.
اوكي دكتورة، الكويك كويشنز لان الاسئله ما شاء الله كذا فجأة طلجت كلها سوا. طيب another question يقول لك do you aware of any reports يعني يتكلم عن النمبرز اعتقد او الستاتستكس او احصائيات او شيء زي كذا.
I had something very interesting because I didn't have enough time to present. I wanted to show you how things have changed in Saudi over time. They started in one of the years, they only had 11 reported cases, and how that became 20-something thousand in 3 years, I believe. I'm not very sure. I don't remember the exact numbers, but you do remember that one year it was only 11 reported cases because, again, socially it was normal to beat a child. Socially it was okay, للأب يأدب ابنه and things like that. And there were not agencies that really were there to support children. The other thing is about the numbers. When they started the hotline, most of the calls at first were people testing if they're going to answer or not. So they received a high volume of calls, but most of them were only people testing if they ever need to call. But things are getting better, and as I told you, I tested myself. They respond immediately, and then the rest of this call, I was actually talking to the dispatcher and asking her about the system. They have a very well-established system around the clock, 24/7.
Okay, دكتورة, another question إنه when to report يعني after the child and parents leave the clinic or while they are still in. برضو في سؤال ثاني نفس الشيء بالعربي مكتوب هل البلاغ سري؟ أتكلم نفس الشيء يعني.
Okay, so what happens is you treat the child and you can dismiss. It is not your job to take care of it after that, and then you report immediately. They will go and investigate. It doesn't need to be while the child is in the clinic, but you need to do the most treatment that you can for the child. هل البلاغ سري? Yes, it is very confidential. You have the option to be updated about the case. This is one thing I did not mention. When I asked the dispatcher, she told me that once you report, you will remain anonymous. The abusive parent or whomever you reported against will never know who made the call. However, if you want to be updated and you want to follow up on this patient, they can keep you posted since you made the initial report.
Okay, دكتورة ديما. في برضو another question إنه did you personally يعني face one of the cases؟ في question زي كذا.
Personally face?
In your career. Yes.
Not that I remember. Not that I remember that I faced a case. Again, there was something socially acceptable for the mom. There was a mom who was not Saudi. She was pregnant. You can tell that very low socioeconomic, they come from a very low socioeconomic status. And she was threatening to hit the child, but she did not hit him. And it seemed like this was the norm dynamic in the house. And we spoke to the mom. She did not hit him in front of us. There was nothing, the child was not bruised or anything, but we spoke to her that she has to be patient, even if the child did not open his mouth. I understand she was also pregnant and, not feeling her best. And we spoke to her, but beyond that, I do not remember any cases of abuse in my practice, and the time I was teaching at the university.
Okay, دكتورة ديما, نفس الكويشن أعتقد إنه هذا very important للبيدياتريك dentist يعني for parents abuse the child in front of us in the clinic. طبعا احنا نتكلم على مثلا resident ولا الجونيورز يعني الكوليجز الجونيورز what we can do or what can be done if they abuse him. يعني احيانا يعني خلينا نقولها مثلا بالعاميه اوكي هم اور بالانجلش يعني لانه انا دائما اقول في عندنا يعني audience بالانجلش فيعني if the parents يعني want the child to be treated okay whether they're going with voice control pushing the child to the chair or something what we can do.
Okay, if you see that the parent is becoming a little bit too violent, you can ask the parent to leave the room. Tell them maybe it doesn't seem that the parent is helping with the child. When the parent becomes aggressive, it usually doesn't help. It makes things even worse. You can ask the mom to leave and tell her, I will deal with it, and expect that you might do less than ideal treatment. Maybe you'll do shorter treatment. Maybe you just temporize the tooth for the child. But don't allow things like this to happen in your clinic. And you can speak to the mom later or the dad later that, this is sometimes you're frustrated and you just want it to get it over with, but this is not really the way to do it. It just harms the child even more, makes the child rebel, make the child very aggressive. And, aggression only creates aggression. And, speak to the parents. And if you're not comfortable with the parent being in the room, I think you have all the right to ask them to leave.
Okay, دكتورة في هنا برضو we have يعني very I think it's important question anonymous يعني attendee asking doctor I had a patient he can't speak okay and there were an abuse signs he came from يعني I think urban care okay and they told me that they find the child with these signs should I report it signs the child but express it the child cannot speak so I mean is it the rule in other words is it the rule to the pediatric dentist or any dentist to investigate or
yes,
if it is not clear
it is an obligation, doctor. It's not only like is it my role or not, it's an obligation. If you have enough reason to suspect abuse, you have to be the voice for that child. Whether the child cannot speak because he's too young, because he cannot speak because there's a language, you don't understand it because there's a language barrier, or the child has been emotionally devastated that the child is not speaking. Again, remember the photo of the Iraqi girl I put? Just look at children's faces. You can sometimes really tell what is happening with this child. And if you have reason to suspect, you report. And again, if it's a false alarm, there's no liability on you, but you gave the child a chance. Sometimes you really need to be the voice for the children who cannot speak.
Okay, Dr. Adima, we have here also a technical question. I think it's from a pediatric dentist. He's asking about, can we consider hand over mouth as a form of abuse? Okay, and can you talk about this a little bit? I mean, because some of the pediatric dentists, especially the postgraduate student, they hear about it. Maybe they didn't find anybody now doing it because it's banned already, but can you tell us about it?
So hand over mouth have been used in the past, definitely more often than it's being used today. Hand over mouth actually requires a consent on its own. So it is considered type of the advanced behavior guidance. You need to consent that you're going to put your hand over the child's mouth. I personally don't like it, in all honesty, but sometimes it can calm a crying child. It depends on how you do it. If you smack your hand there, like on the mouth and try to like suffocate the kid, yes, obviously this is abuse or this is wrong action to do. But if you gently put your hands on the lips, for example, and say, "Shh, I cannot hear you when you cry. You're going to need to talk to me calmly." I think that's even better. But if you can not use hand over mouth altogether, it's much better. And again, remember, you need the consent for that. You can use voice control, you can use positive reinforcement, distraction, tell and do, all without consent, obviously. But for hand over mouth, you need the consent, and try not to use it.
Okay, Doctor, another quick question. Can we take a picture of the abused landmark without a photographic consent? For example, I mean, if you are as a clinician and you're afraid that the parents will go away for what they did or something. Can you take, I mean, you will ask them, is it your rule to take picture to document this, or you just report to the authority?
It is not your role. It is certainly not your role to take photos. And a very important thing that I need to mention, you cannot expose body parts, meaning the child came with a long sleeve, for example, and you saw some bruises on his hands. Or for example, he was wearing a t-shirt and you can see something on the arm. You cannot expose more than you actually see. So you need to make up your investigation based on what you see only. You cannot expose body parts, and it is not your job to take photos. If you manage to take photos, for example, there's something on the chin and you're, you know, like pretending taking like a side profile photo or something, you can do that, but it is not your job, and nobody is going to ask you in your report, like, what documents do you have to support your story?
Okay, Dr. Adima, I have here, I mean, interesting question, actually. Yeah, here he said here, what about pediatric dentists who abuse their patient? The doctor was screaming and pushing the child on the dental chair. I'm a general dentist interested in pedo, and I have witnessed that. So if you find one of your colleagues, yeah, I mean, if you find one of your colleagues doing something you think it's not the right way to manage, what you can do, and he's your colleague or he's a dentist or whatever,
I would probably ask them if they need help, and I say, like, do you need help? Sometimes, you know, kids benefit from seeing a different face, and let me try my approach with the child. I'm not going to necessarily tell the doctor, like, you need to go out now, it's my turn to try, you're doing something wrong. But later I can speak casually to the doctor and tell him, you know, sometimes children do make us, you know, lose our tempers, and sometimes we have hectic days and blah, blah, blah. And it is generally when you feel like you really have reached your threshold, better step out and let somebody come in and finish. And you know, we all go through that. Sometimes you really can't focus, you really can't see, you had a very long day, very stressful day, you're not at your best shape. It is not a problem to ask for help for somebody else to come. And sometimes really changing faces can help the patient. Maybe, you know, the patient did not get along, or this doctor, for example, resembles the patient's, you know, reminds the patient of a negative experience. Have somebody else come, but definitely don't allow it to continue. But you have to be very diplomatic.
Okay, Dr. Adima, the last quick questions, the last two questions, very quick, please. I mean, I think it's interesting subject, a lot of questions, I mean, different even questions. Okay, some people, this is from Dr. Manal, okay, some people believe that hitting a child is considered a discipline to make the child behaves well. What is your opinion about this? طبعا يمكن يقصدون يعني نقولها بالعامية نوع يعني أو الضرب الخفيف أو نوع من التأديب أو كذا. What do you think about this?
Well, I'm not an expert. I can't tell you. I came from a generation when that was normal, and then we all of a sudden became parents, and that's not normal anymore. I don't know. I do know that you cannot really harm the child. I mean, sometimes you see a little smack, the child is trying to touch something hot, and then you do this to the child. I'm not an expert, and I don't know, and I can't advocate for one way or the other. I just prefer if we can always, you know, like stay composed and not need to hit children, and, you know, find something else to do. And I mean, yeah, we can always lose our tempers, and but we have to really try hard not to hit the children.
Okay, Doctor, last question. Can we, I mean, this question, it goes a long time, okay, but I remember it because it's a good question. Can we consider dental neglect? I mean, you know that in the United States or in other countries, if the child is neglected, you might report it to the authority. But I mean here, because we have high-risk carers patients, a lot of them, and some of them due to lack of education or something to the parent, because it's not from their culture to brush their children's teeth. Can we consider this I mean, a kind of abuse or something, or neglect, or it's normal in our society due to the background of the education of the parents and the etc.
Scientifically speaking, it is neglect. If the parent knows the magnitude and understands the consequences you really explain to them that, you know, this temporary teeth concept is wrong, and these teeth are there for a function. They even affect the health of the permanent teeth and all of that. You really explained, and not just explained, and made sure they understand, and they have no good reason not to bring the child. It's not a financial burden. It's not an issue like that. I think it certainly scientifically is neglect, and I think you would report it and see what the authorities do with that. I mean, I wish they take action similar to this to anti-vax moms. You know, the new trend where they don't want to vaccinate their children, or they don't want to use fluoridated toothpaste. Every now and then somebody comes with, you know, an idea, but you have to explain to them from a scientific point of view what is happening, make sure they understand, and that they decided not to bring the child without any valid reason. It's just because it's of you know, low priority on their to-do list.
Okay. Thank you, Dr. Dima Farsi. Thank you a lot for this informative lecture. Actually, we have a lot of questions. Anybody we couldn't answer the question, they can, I think Dr. Dima will be more than happy to answer your concern and question. She has a Twitter account. Okay, it will be in our Twitter account. We will put it so you can address the question to her directly, and inshallah she will be more than happy to help in that due to the time limitation here. Thank you very much, Dr. Dima. Do you want to tell anything at the end?
Yeah, can I give my email? It's just much better. I don't know how I'll be able to communicate on Twitter, but I can definitely, can I type my email here?
Go ahead.
Sorry. So please email me if you have any questions or any concerns. And if you need, I try to answer the questions as brief as possible and make the answers very concise. But if you need more information, please let me know. Okay. Perfect. Thank you so much, Doctor.
Okay, thank you, دكتورة. طبعا ايميل الدكتورة اللي هو D FARCI. Okay. طلع على السكرين, and also she can put it in her Twitter account also for anybody who contacted her or something. I mean, we will put the email inshallah later. Thank you very much, Dr. Dima, for your information. Okay, hope inshallah to have you again in the Saudi Society of Pediatric Dentistry, inshallah. Thank you, Doctora. I will move to the second guest, but let me introduce, وخلينا نقولها بالعربي. نرحب بالدكتورة second moderator معانا اليوم إن شاء الله اللي حتشاركنا الدكتورة وسام دمنهوري. طبعا الدكتورة وسام غنية عن التعريف. She's American Board Certified Dentist and a Clinical Audit Director at King Fahd Hospital in Jeddah, and she's also member of the Scientific Committee of the Saudi Board in Pediatric Dentistry, and she will introduce the second guest. أهلا وسهلا دكتورة وسام. The mic is yours.
أهلا دكتور تميمي. Good evening, everybody. Thank you, Doctor. I'm honored to be part of this, and I would like to take the opportunity to acknowledge Dr. Farsi's lecture. Thank you, Dima. And not to keep you waiting, I would like to introduce Dr. Rima Al-Rakia. Tonight, Dr. Al-Rakia is a senior registrar in the Pediatric Dental Department at King Fahd Armed Forces Hospital. She's holding a PhD and a master's degree in pediatric dentistry, and she's currently a member of Prince Salman Autistic Center at King Fahd Armed Forces Hospital. She is a teacher. She's in a teacher. She is a lecturer at Western Region for the General Dentist Training Program at King Fahd Armed Forces Hospital in Jeddah. I like your topic, Dr. Reem. Ahlan wa sahlan biki. She's gonna present tonight the management of autistic patients in dental setting, behavior and recommendations. Actually, with the growth of and increased diagnosis of autism, group needs more attention, and I really looking forward to hear what you're gonna say about it. And best of luck, Dr. Reem. The mic is yours.
السلام عليكم. أهلين دكتورة، يعطيك العافية. Thank you for your nice introduction, and Dr. Dima, thank you for your informative and nice lecture. So let's start. My topic today is about management of autistic patients in dental setting, behavioral approaches, and recommendation. Is the voice clear, please? Okay. So in the beginning, the autism spectrum disorder, as well known, it's a complex neurodevelopment disorder. It's a neurodevelopmental disorder that is defined as behavioral syndrome, consists of impaired social interaction, as well as sensory motor deficient and combined with stereotype and restrict behaviors. Also, it has some motor difficulties, intellectual disabilities, as well as attention and physical health problems, as gastrointestinal disturbance and sleep disorders. Quick facts about autism. Autism is increasing in Saudi Arabia, and so the autistic children are being part of our society. Boys are nearly affected 5 times than girls, and early intervention programs are useful for providing both diagnosis and strategies that promote more positive long-term outcomes for children. With such high prevalence rate, dental professionals will most likely encounter patients with autism during their career. And the greater risk for oral health problem is increasing as up as to 15% because they are not receiving any dental care. So having these behavioral and social disorders, different types of medications they are taking, difficulties in sensory processing and integration, as well as other medical problems, these are all factors that are challenging during dental treatment. Mainly, our presentation will be about the behavioral and social disorders. As we know that the patients who have autism, they are facing difficulties with changes in routine, oversensitivity to sound, excessive obsession over a topic, lack of awareness, inappropriate laughing or crying, difficulty in making friends, delayed speech. Lots of these stuff are facing us in our dental treatment and affect our dental treatment. So what are the autistic behavior characteristics that are related to the dental visits? As we all know that the dental office, it's a very noisy environment. You have the lights, you have the dental lights, you have the noise from the hand pieces, all these things, as well as the different smells, temperature variation, all these things can affect their behavior. You might suffer from aggressive, disruptive behaviors due to their personality and what they are suffering from. As well as the routine change, such as going to the dental office, again, can be expressed in form of phobia and anxiety. Lack of response, eye contact, as well as interaction with the environment, all these factors may obscure oral care proceeding. Physical and verbal aggregation, and this especially can happen with young autistic patients as withdrawal. They can escape from the clinic suddenly as a consequence of aggravated sensory processing. So, what is the importance of behavioral approach? The goal of behavioral approach is to minimize the anxiety, provide quality dental treatment, and building a trusting and positive relationship for a lifetime between the dentist and patient. There are many types of behavioral approach. But before we start any type of this behavioral approach, I want to remind you that each patient has its own behavioral approach, its own characteristic, okay? And it is important that the parents can understand that it will take time until we get to the correct and suitable treatment for each child. So, and at the same time, you need always to make the concern of the parents' preference, what they like and what they don't like, what is their concern, what is their preference in the dental treatment. So first behavioral approach, it will be home-based preparation. It is always better to start with the parents or caregivers or the therapist. Okay, and we try to work together as a team to have a successful visit. It means that we start with the mother or the parents, pre-teaching. I will ask the mother to do lots of social stories for her kid, reading social stories, reviewing visual schedules, especially if they are non-verbal. So she can bring all these stuff from the internet, and she start to read for him about the dental visit and what will happen in the dental visit, just to try to calm the patient before the dental visit. As well as contacting the physician and therapist, the dentist should contact the physician and therapist to know about the type of medication he is taking, whether the medication is affecting his dental health in form of xerostonia, in form of gingival enlargement, and what are the inappropriate behaviors, how we can avoid these inappropriate behaviors so we can deal with them in a good way and a good manner. This is a picture showing how is the doctor is calling to the mom pre-dental visit to know from her every and single information about behavioral profile, behavioral shaping, disruptive behavior, how she's dealing with him, how she's communicating with the child. And it is important to put the dental treatment in a day that the patient is relaxed. He has no another session with the therapist or at the school, and it should be suitable for both the parents and the kid. As well as I said, you need to, the parents, they need to read lots of stories for their kid to calm the kid, and always remind the kid that we will have a positive reinforcement like a gift or something he likes to have a good dental treatment. And we ask the mother to try to calm him, to bring with her the toys that he loves, if he likes the iPad, anything that can distract him in the waiting area. And finally, again, it is important for the mom to reassure her child or her child that he will have a good, inshallah, dental visit. The other behavioral approach, it's on the appointment structure. The appointment should be short, well-organized period in the waiting area. The waiting area shouldn't be full of patients or pictures, and it should be less than 10 to 15 minutes. The day when you have the patient, your receptionist, your dental assistant should know that you have an autistic patient, so she can welcome him in a very good way and in a nice manner. Communication. If the patient is verbal, then the oral commands should be short, clear, and simple sentences. If the patient is nonverbal or he has some speech delay, we will ask the mother to help us how she can deal with her child, how she can communicate with her child, and we will ask about a PICS system. PICS system, it's a picture exchange communication system. Okay, this system is a very nice system. It's like a book or file. It contains multiple pictures that the child using it daily. Okay, this system is mainly can be started with the speech therapist. The speech therapist train the child, first of all, how to exchange the cards, even without pictures. First of all, she needs to train the child how to exchange a picture in a form of the cards, in a mean that if you want something, you need to take the card from the file or the book and give it to your parents, and then the parent will know that you want something, okay? And then after that, when the child knows the idea of exchanging the cards, we start with the pictures. For example, the child wants water. He will take the picture of water, and we will go to his mom or dad or the caregiver. We'll put the picture on the hand, and then the mom will say water. She will say again water. The child will start to store these words in his mind until he can spell it again and tell it again. This system is very nice. At the end, they can also make a sentence. For example, as here, I want juice, instead of doing behaviors, disruptive behaviors in ordering what they ever want. Once we are sure that the patient knows the pics, then we can also use these pics in our dental clinic. I can show him the mirror, I can show him the dental seat, the x-rays through the picture. I can communicate with him through the picture whenever he is tired or he doesn't want the treatment or he feels something sad or something. I can exchange the picture so I can understand what he wants. The other type of behavioral approach is tell, show, and do. And this is also a very nice way of behavioral shaping, and we can use it also with normal kids. Here, I'm telling them the steps of my dental visit, and I will let him know that after the steps, I will give him a prize, and this prize according to what he likes. Okay, and I will make sure that I will explain each steps before I start. I might show him again pictures just to make him more relaxed and calm to the way I'm doing. The other articles show that there is another behavioral approach called tell, show, feel, and do. And here we need to make sure with the parents or caregiver is they are hypersensitive to touch, hypersensitive to smell. So here I cannot use the feel, okay? I will only use tell, show, and do, because if I bring for them something noisy or unacceptable, they might cause a disruptive behavior, as I mentioned before, okay? Other behavioral approach is restraints and deep pressure touch. McDonald and Array reported that to obtain safer and more predictable working condition, restraints can be used in challenged patient. And here, when I use the restraint, I should always take a consent from the parents. And before this visit, I always try to explain the mother or the parents what is the meaning of restraint and how we restrain the child and how much it is important to restrain the child to get his dental treatment. Other study report a more or less firm wrap. It is very similar to our dental x-ray gowns. They are heavy. They are called heavy blankets or wrapped heavy blankets. And you can find it in the internet. They are heavy blanket. We put it on the patient so they can feel secure. They feel that they are hugged with this blanket and they will not fall down and they can be calm during your dental visit. And again here, we need to ask if they are hypersensitive, they have problem with the hugged, so you cannot use this blanket or you cannot use the restraints. Desensitization. The desensitization, it's a gradual approach to learning or tolerate the dental procedure. It's involved a series of short visits. Each visit, we will practice the same skill or the same step, and I will give a positive report accordingly. And it is important that these steps to be practiced at home with the parents or peers and or with their therapist. We can help them with personalized photography, toys, to help them more in the desensitization strategy. This is an example. Here, this is the dental chair. For example, in the first visit, I bring the patient, I let him sit on the dental chair for 5 seconds only, and then I appraise him with a great job sticker or whatever he likes. And then the second visit, the third visit, 30 seconds, I increase the time until I reach, for example, 15 minutes, until I reach that the child is ready to sit on the dental chair. He is accepting the dental chair. The visit after, I will start only dental checkup and counting of tooth for them. These steps are very long steps. It needs from us to be patient and from the parents to be cooperative. We need to convince them about the treatment, about the way of behavior shaping, to help us and to reach to this grateful results that they can sit on the dental chair. Behavioral approach, the other behavioral approach is the ABA, which is the applied behavioral analysis, and it's one type of learning theory. In this type, for example, here I have brushing teeth, okay? what I did, the skill, we divided the skill into a very small steps. For example, get the toothbrush, and then I will put a click or smile or star. Then get toothpaste, and then put the toothpaste on toothbrush. Turn on water. Wet the toothpaste. Wet the toothbrush. Every time, this is called functional analysis, to teach specific skills. Every time he will do with you, or she will do with you, with the parents, the specific steps, and he will come to the dental office and we will do the same. At the end, we will end up that he will take the toothbrush and he will do it as a routine, as a normal daily routine. He won't do the steps alone. He will do it immediately, okay? And this is a very nice example of ABA. Distractions, and this is a very good ideas about activities or objects that may distract the child. And here we need to work with the parents to develop a plan. We should know from the parents what the child likes. Does he like to listen to some music? Does he like to see any movies? If she or he is attached to any toy that can calm her or him on the dental chair. Okay, sensory technique, again, this is also called a teaching technique, okay? For example, when the patient comes, I will train with him the skills of toothbrushing, and at the same time I will try different techniques of toothbrushing, with sometimes with the electronic toothbrush, sometimes without electronic toothbrush. I will try the wet cloth until we can reach to a suitable setting in the dental chair, so I can reach to him in a successful treatment plan. Okay, I might use also different toothpaste until we can reach to the suitable toothpaste he needs. Social stories, as I mentioned it before, again, you can find it in the internet. There are series of colored photography describing step-by-step any events. For example, dental visits. Some of autistic patients, they are visual learning. You will find for them something called visual pedagogy. It is something, it's like a book, but mainly it is about colored picture more than the words, so it won't distract them because they are visual learning. They learn through pictures and colors, and they are very informative books where they can find lots of information. So to have a successful visit, you need to start from the parents, pre-visit parents consultation. You need to ask everything about the child, the behavior profile, behavior, how the mother is communicating with this child, the medical history of the child, the dental history of the child. Does he have any previous experience with the dentist? And how it was, okay? And then a child's home preparation, it's very important to have a successful visit. And dental appointment, it depends on us, how we can do and modify our behavioral approach to reach to this child, and to put in mind that each child has its own profile and its own characteristic. And then we can, after that, make a good dental professional plan to make the dental treatment for him in a calming and a nice condition. So as a conclusion, autistic individuals exhibit wide variation in abilities, intelligence, and performance. Dental practitioners may need to target their therapeutic approach to the unique characteristic of each presenting child. The dentist will learn more about the behavioral strategies of the child through their parents, and the parents are important member of the child's dental health care delivery team. A successful management requires coordinating the efforts of educator, therapist, physician, and mental health professional. As I told you, it's a team work. And before I say thank you, I want to dedicate the Light Up in Blue to the international awareness of autism, to support the awareness of the Dental Autism Awareness Day and Dental Autism Awareness Month. And thank you very much. Hope that you enjoyed my lecture. Thank you very much.
يعطيك العافية دكتورة ريم. I really enjoyed your informative lecture. It's a nice review actually for all of us, and There was a couple of questions for you. And one of the questions is, how can we differentiate between social phobia and autism? And what are management routes for those cases? If you may answer that question, please.
The autistic patient, they come with already, they are already diagnosed with autism. And you can find some elements like they don't have a good eye contact. You can feel and you can know that this is an autistic patient through their behaviors. So it's totally different than social afraid.
All right. Another question. Is there any pharmacological behavior management techniques or sedation we can use with such group?
Yeah. If we failed with all these behavioral approach, or if the patient is from the beginning diagnosed with severe autism, then we will go and shift with the behavior, with the pharmacological behavioral approach, which is the nitrous oxide. And some literature, they don't prefer the nitrous oxide and oral sedation, especially with severe autistic form. So we shift to general anesthesia.
Okay. Another question. Is it better to have the same dental team for all visits for autism child?
Yes, and this is part of desensitization, that you're having the same team, you're doing the same steps equally and similar, the same, and this is better for them.
Okay. Regarding, do you manage these patients' chair side successfully? Personally, do you succeed with every single case?
Not with every single case, but I have cases that we are working with them. We are putting for them some songs they love, some cartoons they love, and I try to make the appointment very short, and they left happy, alhamdulillah.
All right. Do you think there's any references to manage those cases online, like interactive task books?
Yeah, you will find
or guidelines, or we just like treat the patient as a package, whatever he comes with, we just deal with it?
No. You will find lots of information, lots of social stories, visual pedagogy, everything. You will find it in the internet, in a website. Literature reviews, all these can help you in dealing with patients.
Someone else is asking, is there any characteristic oral findings for this special group?
Yes, they have lots of paroxysm because they have a self-mutilation. They might, you can find, they might, they have nail bites, and they can bite stuffed things that they can break their teeth. Plus the caries, because they're having a pouching, pouch the food, okay, because their muscles are very weak, so they used to pouch their food, so you'll find more plaques and then lots of caries and gingival problem. As well as the medication, they have xerostomia with the medications, and sometimes tongue discoloration. All these affect their oral health.
Okay. You mentioned something about nitrous oxide. Usually autistic patients are claustrophobic.
Yeah.
They're afraid of touch, they're afraid of close places.
Yeah.
So how often treating those cases under nitrous oxide would be successful?
It's very hard to treat them under nitrous oxide. That's why I use it only for emergency, for a single tooth with abscess. And by the aid with the parents, they try to help me, because although I put the restraint, they can open it easily. Because, as I mentioned, they have a very aggressive and disruptive behaviors. But I only use it in the emergencies treatment.
Do you think general dentists would play a great role with those cases, or do you prefer them to be referred to a specialist or a consultant?
I wish that everyone can treat the autistic patients. They deserve to have the care from all of us because they are part of our society. And treating them is rewarding and challenging.
Yeah, of course. Most of the time, how many visits will you give the child before you shift him to GA? This is one of the questions.
Before I give, I will try from the first visit. If I did not succeed, I shift him to the general anesthesia. I won't wait for them.
Okay. Someone is asking, can I use desensitization to improve their behavior?
Desensitization to improve behavior? How?
Mm-hmm. The technique of desensitizing.
Yes, yes.
Like get them familiarized by the clinic.
Especially if they are very young autistic patient, especially if they have a very light autistic condition, you may succeed. And you will have a great results.
All right. From my personal experience, even when we shift them to GA, the pre-op procedure is really quite devastating. So, so it's not really easy either way, you know.
Yeah.
Do you?
In our hospital, we are working as a team. Once the patient is suggested for general anesthesia, we have a special pediatrics and special anesthesiologist to deal with them, even in the lab when they want to do a blood test before the GA. We have a special team that they can work with the autistic patients.
All right. Another question, Doctora, do you recommend orthodontic treatment or myofascial therapy in these children? Or is it challenging as well?
Yeah, it's very challenging on them. Again, it depends on the patients. It depends on the patient's behavior and his diagnosis. If he's severe, we cannot do for him anything. We cannot offer the help of orthodontic.
All right. In cases, there's an autistic patient who communicate well and respond to chat and orders. Is there in their first visit in our clinic, but receive dental treatment before?
Yeah.
How to manage them?
I will start again with the behavioral approach. I won't do any treatment until I calm the patient and gain the trust.
You know, by definition, and MOH, I think everywhere, pediatric patient was defined in regards to age from 0 to 14, 12, 14, it depends, you know. One of the audience been asking, up to what age do you follow up with the autistic patient?
Well, in our hospital, we work with them till the age of 11. Till 11,
right.
Until they finish all their primary.
It depends on the institute and the ministry you're coming from, the guidelines. But how easy is it, like after he's getting used to you, you know, he's familiarized with you and your clinic and your team, and all of a sudden he had to switch to an adult clinic or a different doctor. How easy is this transferring process going to be for the patient?
Yeah, I didn't.
They're going to be like starting from ground zero, you know?
Yeah, I didn't try it before, but I guess, yeah, we will start from zero. We will try to, like when we shift from grade 6 to grade 7, we try to introduce them what's going to happen. Like this we will do.
All right. Do you, Yani, in the next level or the next clinic he goes, do you go in the first time? Familiarize him?
For me, maybe
you're going to be okay?
Yeah.
You would?
Maybe I will do it.
Yeah, okay.
Yeah.
One of the dentists been asking, she met a patient, autistic patient with severe crowding, and how we're going to manage him after GA rehab. Like she took him under GA, she did full mouth rehab, but he really suffered from severe crowding. And would we just leave him and continue with follow-up prophy fluoride and checkups?
Yeah, we cannot do any orthodontic management for them. It's very difficult.
Not even milder cases?
Milder cases,
At least a space maintain
yeah,
remaining,
it depends on
if
the
it's
patient.
possible.
Yeah, how cooperative the patient is, especially after the GA. Sometimes they don't cooperate immediately. They take time again to be cooperative.
Perfect. Actually, we went through most of the questions, the reliable questions. Some of them repeated, some of them unrelated. So there's one here. Thank you so much for the lecture, Dr. Reem, but I have a comment on the title. No, let them. Just I will skip that question. And I would like really to thank you for your lecture. And if you have any further announcement or any further comments, and the floor is yours.
Thank you very much. Thank you very much all for having this nice meeting. And that's it. Stay home, stay safe, and happy Ramadan for all.
إن شاء الله رمضان كريم على الجميع يا رب.
أكيد.
I would like to hand you to Dr. Tamimi, and I would like to thank you, and I would see you soon, inshallah.
Inshallah. Thank you, Dr. Nice to meet you.
Nice to meet you. Thank you, Dr. Reem. Thank you, Dr. Wissam. Thank you very much. And I would like also, we're gonna give them a certificate for Dr. Dima and also Dr. Reem والمودريتور اللي معانا Dr. Wissam. Thank you very much for being with us tonight. And also, thank you for everybody. I just want to have an announcement for the next week, inshallah. Next week it will be, inshallah, Ramadan, Wednesday. So we will start at 10 o'clock, okay, for 2 hours. And it's a very interesting topic. Will be next week. The first one will be communication in the dental office by Dr. Bashair Abdelhadi, and also smart treatment options in pediatric dentistry by Dr. Abdel Fattah Al-Abma. It's really interesting topics for the clinicians, for anybody, interns, GPs, residents, specialists who's interested also in the clinical treatment of pediatric patient. They are welcome all to join us next week. I think it will be also another informative webinar. Also, I want to tell something at the end. This society is your society. All the pediatric dentists, everybody, all the GPs, all the interns, everybody interesting in the pediatric dentistry. This is your society. Being a member in the society will help us to be a bigger society, inshallah, with the time. Now we have different steps, inshallah, these days. Also, these lectures, you will find it. We have a YouTube channel. You can find the lectures, and also it will be posted in our website. We will have also a new website, inshallah, soon. And we want everybody to interact with the society and to register to be a member, and also to have the credit hours, the weekly credit hours for the membership. Okay, but everybody, even if they are not member, will get a certificate, but the hours will be for the members only. Thank you all. Thank you for all the audience, and hope, inshallah, to see you, inshallah, next week. Thank you. Ramadan Kareem. كل عام وانتم بخير.